We want to get your intro.
Okay. Hi, everyone. It's a pleasure to welcome Professor Adam Hedgecoe to our seminar. Adam is a sociologist, and his work combines medical sociology, bioethics, and STS. Interestingly, the bioethics side, and some work with bioethics as an object of inquiry, but also asking the question, what is it that social scientists can think about ethicists? His work on pharmacogenetics, multiplication related to clinical decision making. Just in case you were busy surviving a pandemic in 2020, he published Trust in the System, Research Ethics, Committees and the Regulation of Biomedical Research. It was published by Manchester University Press. And it's a really good example, of course, it's the outcome of years of research, where you really did the sociological institutional work showing these processes, how the trustworthiness of medical researchers was assessed by these in the decision-making settings. So yeah, it's a great piece of scholarship. And today he's going to talk to us about tactical reporting, actionability, and uncertainty.
Thank you very much. Lovely to be back here at Egenis, which obviously my time at Egenis, I'm familiar with the centre, with the building, soon to be renamed building, I learned. It's not being renamed. Okay.
Not yet.
And actually, I realised the last time I came to Egenis to give a paper was actually just before I started. It was in 2009, just before I started the Cardiff. So this is different. This is a different paper to the one that I originally said I would do. The one I originally said I'd do, I kind of know what I think about it, and I know what's going on there. This I don't. I don't know if there's anything here. So it seems to me I probably need to bring this along to a group of people who might help me think about whether there is anything here, whether there's a story here, whether it's interesting or banal or worth pursuing. So the broad context for this paper is the modern NHS. And modern NHS, if you listen to some members of the sort of policy community, like Sally Davis, who was the chief medical officer in 2016, then the modern NHS is genomic. So this is the CMO's annual report from 2016 called Generation Genome. And it's a real positive picture of the potential for genomics in various forms to enhance the health and the sort of health-making activities of the NHS. From Sally Davis to Matt Hancock, and even in the middle of a pandemic, Matt Hancock was talking about how important genomics is. So this is from his speech to the ABPI, the Association of British Pharmaceutical Industry Annual Conference. We're making genomic sequencing a routine part of everyday diagnosis and treatment. And this is a key part of the discourse around here, is that the NHS is a particularly interesting place to do this. That the nature of the NHS, the nature of a single, of course it's not single, healthcare system for the whole country, with consistency of record keeping, consistent access to healthcare, means that genomics is a really that the NHS is the right place to do. Okay, so that's the broad background. So the focus for this is about, okay, what do we do with genomics in the NHS? How is it to lean on a term that is used broadly both by social scientists and from practitioners, the idea of actionability. What is the actionability of these genetic or genomic tests? And there's considerable debate here. Serena's contributed to work around discussion around actionability. This is I'm going to say classic but not uncontroversial statement around actionability. So this comes from Nicole Nelson and Peter Keating and Alberto Cambrosio. And their argument is that actually only a small subset of genetic tests, clinical genetic tests available at the moment, are actually actionable. And they're the ones that you use to help decide how to prescribe drugs, particularly cancer drugs. Actionability acts as a performative classifier that assigns certain molecular entities to a distinct categories. Potential actionability of sequencing results centered on a molecular hypothesis about drug action. So this is one way of thinking about actionability, that if you like, normal genetic tests that tell you about whether you have a gene that predisposes you to a genetic condition, or whether that's used to diagnose your child's sort of developmental disorder. These aren't actionable tests. There are alternatives. This is taken from a paper in the annual review of genomics and human genetics. This is a kind of little cartoon here. This has lots of different ways in which genetic testing for disease could be actionable, both for the person, for family, for society. And in clinical terms and non-clinical terms. So this is the alternative, is that these kinds of tests are very actionable. There's a lot going on. And it's even been suggested that even genetic tests, even uncertainty about genetic tests, even genetic tests where you don't end up with a clear answer, can be actionable. They can be used productively as a means to spread a genetic agenda, create new genetic knowledge, and keep the patients under genetic purview. But even if you don't have a definite genetic answer, the test itself is actionable. It keeps patients enrolled in the clinic, and you can come back and see them later on when perhaps you have more information. Okay, so what I'm presenting here are results from a Wellcome Trust funded project that I ran from 2016, 2019. I had various collaborators on this. Kathleen Job was the research assistant who worked specifically on the data I'm presenting today. Clinical collaborator was Angus Clark, who might be known to some of you. Angus is a clinical geneticist at the University Hospital Wales and a honorary consultant in the Cardiff Medical School. And Rachel Hale worked with me on the other arm of the study, which is more patient-facing, which I'm not going to be able to talk about today. So this was an observational study. So we were interested in professionals talking about ambiguous genetic results. One of the things that something like the lovely, flashy Generation Genome Chief Medical Officer's annual report from 2016 doesn't talk about is it doesn't talk about how many results that come out from sequencing machines are really ambiguous. So some statements suggest that 40% of the results coming out for BRCA testing are this ambiguous kind of result called a variant of uncertain significance. So that's the core of the study. We are interested in, okay, so clinical geneticists have a complicated, ambiguous, vague result. By and large, they don't like complicated, vague results. They want to be able to give the patients an answer. So how do they make a decision about that? So this is, we did we sat in on meetings. And we sat in on different kinds of meetings. We sat in on the weekly prenatal testing meetings, the medical genetics cases. So a whole load of different professional meetings. The kind of numbers of people will vary from 5 to 30. depending on the specifics. So the things like the inherited cardiac disease meetings were much smaller. And the makeup of the meetings would vary. Something like an inherited cardiac disease or cancer risk review would have clinicians from the specific area. So you'd have an oncologist or a cardiologist with an interest in those specific conditions. Something like the genomics MDT, for example, or dysmorphology clinic meetings. By and large, we're talking about clinical geneticists, genetic counselors, some people from the lab, but very few clinicians from outside, unless there's a specifically interesting case and they're being invited. Oh. So the focus is uncertainty, or removing uncertainty, is moving away, is how do you make decisions about VUS, variants for which the evidence is insufficient to determine whether they are deleterious or benign. So there's fairly standard ways of doing it, and actually quite soon after we started observation, the team that we were observing, the clinic that we were observing, started, like all teams, like all genomic centres in the UK, started using this. So this is from the American College of Medical Genetics and Genomicists. And it's a whole paper from 2015, which is an attempt to help clinicians decide which bits of information you draw on to make a decision. So, I mean, this is a table. So we have a spectrum on the top layer. That doesn't seem to be working, so there we are. So we have.
If you use your mouse on this screen.
Okay.
Yeah.
There we go.
There we see.
So here we have very strong evidence for that the gene or the variant in question is pathogenic. There we are, and that's the nickname for that, if you like, the code name for that is PVSI. And then gradually, over as we move back down here, the evidence becomes less strong for that the variant is pathogenic and stronger that it's benign. And here are the different kinds of information. You could be talking about population data, computational, functional data, what goes wrong if you mess with this gene. Segregation data, which is how it spreads within a particular population. De novo is the variant brand new. You've tested the parents. The parents don't have the variant. The parents don't appear to have the condition in question. So maybe it is causing a problem, but it's brand new in this child. And various other kinds of data. And then the paper from the ACMG very kindly tells you how to add up these different things to make to know that the result is pathogenic or likely pathogenic. So these are just little ways of adding up each of these different categories of strength of data. So one really strong one and one moderately strong result. There we are, added together, then that variant is pathogenic. And the idea is to move from here, where you're sitting in a room a bit like this, talking about a particular variant and a particular patient and a particular phenotype. The idea is to move from here, either here, so you agree that the variant, looking at the data, is causing the condition in question, or it's benign, we don't need to do anything about it. So, to return to the issue of actionability. So if we're thinking about actionability, the conventional understanding of these clinical meetings looks a bit like this. We have a meeting, we have all the resources, the database, the models, we have the results of the test, and the meeting decides it's either benign, it's a VUS, still, no one really likes a VUS, but there might be things we can do. The intervention with a VUS, if you like, what's the actionability of a VUS? Well, you go and find out more data. Maybe you test the parents to try and see if, or else other people in the family to see if the variant is there. Maybe you look at other databases, other resources. And if it's pathogenic, then you assume that the person in question, the child or the adult, has the disease, and then there's a treatment option. What I want to suggest, based on our data, is it's a bit more loopy, it's a bit more messy. So the thing, and this is the question, is there something interesting here, or actually is this not particularly surprising? Is when you look at the conversations that these groups have, you end up with tentative conversations about, for example, that this gene might be pathogenic, this variant might be pathogenic. There's then a conversation about what you might do with that variant if it's pathogenic. So what's the actionability of that variant? And then the decision then becomes the classifiers of the US. So if you like, there's the end point, which is the actionability, is actually part of the process. It's part of the decision-making process. So what I want to do for the rest of this is talk about three different types of justification or warrant for this process, for feeding back, for the ways in which the actionability, the end result, feeds back in the decision-making process and changes the outcome of the actual final decision. What's actually reported, what's written down. So the obvious thing is, so the first category is clinical warrants. So this is where the possible clinical intervention or the clinical use of a variant changes the group's mind as to its actual epistemic status, or what they will say its epistemic status is. It's different. And the first thing is, quite frankly, termination of pregnancy. So as I said, one of the groups we sat in on quite often was the prenatal meeting, which was every Tuesday morning at 9 o'clock. And in a prenatal context, the main intervention that you are talking about is the possibility of terminating pregnancy. And what became clear in data from those meetings and from others, this is actually this stuff is from this case is from a start in a dysmorphology meeting, is just how seriously these clinicians take the possibility of a termination of pregnancy. So this is an interesting case. It's interesting for other reasons, and I've written about this in one of the two papers that we've produced so far from this project. But this is a 14-month-old girl. She was sequenced using a gene panel. She has a variant in a gene called MECP2, which is associated with a developmental disorder called Rett syndrome, which is a sort of rare disorder of the brain. The girl, while she has developmental problems, phenotypically isn't a fantastic fit for Rett syndrome. She doesn't have some of the key symptoms, and she also has a load of other behaviours that don't fit with Rett. So there's a whole debate about whether the girl has Rett or not. It's agreed that they finally agree she's probably, as they call it, Rettish. It's the best diagnosis they have. So the question is, it then becomes more complicated because they decide, well, obviously you test the parent. In fact, the father isn't available. You test the mother. Unfortunately, the mother carries the variant. So then, does the mother have Rett syndrome? So the discussion here, which I can't go into detail, is then a conversation between clinical geneticists as to whether a woman who went to a normal school, did GCSEs, works in a coffee shop, has her life together, busy planning her own wedding, could possibly, if you squint and look at it through a clinical genetics prism, be described as having a developmental disorder, to be somehow intellectually disabled. Now, eventually they decide that she isn't. They still have a problem. There's this variant, and it seems to have a link to this disorder. And then comes a conversation, what would we say to the mother if she became pregnant? So the mother is enrolled in the genetic service. She may well get in contact with us if she's pregnant with another child. So the conversation, we could then talk about offering prenatal testing for this variant. But the conversation would be making clear to her that she might be terminating a perfectly healthy child because there isn't enough certainty about whether this variant is causing this developmental problem in her daughter. In fact, and the child that would be the pregnancy would be terminated would be, as they say there, just like her. So it's a very complex, detailed conversation. And the team then start talking about the kinds of obligations that they have to present to colleagues like obstetricians. So obstetricians are the ones who basically carry the can for termination, but they have to know that they're operating on certain evidence and feel, not unreasonably, feel that the clinical genetics team have to give them clear information. So there's a conversation, and this case sort of kind of reoccurs. It comes back to various meetings. About 6 months later, it becomes a bit more real when it's clear that the mother is pregnant and is asking the service about potential for prenatal testing. So Alan, who's one of the more vocal members of the team, so the question is, could we imagine getting to the point where we'll say, yes, we'll do it, we'll report the variant as pathogenic, and that opens up the possibility for termination of pregnancy. But we have to explain how the level of uncertainty we have here. Jane interrupts him. Are we seriously going to be in a position where we feel sufficiently informed to advise an obstetrician that termination for this is appropriate? And there's some real uncertainty, real discomfort on the part of the team. The flip side is, of course, is if they don't say anything, if they don't offer this, there's a possibility that the child could carry this gene, and there's a possibility of this variant, and there's a possibility that this variant will cause this developmental disorder in the new baby. So it becomes very, very complex. In the end, actually, the team choose to offer the prenatal testing with all the complexities around it, and in fact, the mother doesn't take them up on it. Mother says, "No, look, I'm not interested in testing this." But you can see the ways in which the kinds of discussions, the ways in which, and we've got other examples where it's quite clear that actually decisions to provide the test or decision to classify as pathogenic is the team move away from that decision in the light of the possibility of termination of pregnancy. Okay, so that's termination of pregnancy. This is it's alternative. So this is about this lad here. This is Kath's handwritten family tree notes off the screen in the presentation in the team meeting. So this is a boy with relatively severe congenital myopathy, so that's muscle disorder. And he has 3 variants in a gene called RYR1, which is associated both with congenital myopathy, so that's the phenotype he has, but also a condition called malignant hypothermia. Malignant hypothermia is fine until you have a general anesthetic, and then your body begins to overheat and your muscles begin to go into sort of kind of a shutdown. So it's quite serious. So quite a lot of complicated. So look, they discover this kid, one of the variants is a well-established variant for malignant hypothermia, 7373, and that's carried by the mother's side of the family. And in fact, they have some evidence that there's a cousin with a similar phenotype over here. So that's fine, that's very straightforward. it's quite clear that this lad is at risk of malignant hypothermia, and should he ever have a general anaesthetic, then the anaesthetist and the clinical team should know that. The trouble is, he also appears to have inherited 2 variants in the gene from his father. So there's a possibility he's actually got 2 or even 3 pathogenic variants in the same gene for the same condition at the same time, which is unlucky but not impossible. So what do we do with that? You test that, and if he's got this gene, which at least is somewhere on the border between a VUS and likely pathogenic. So the obvious thing to do is to get more clinical information, is you refer that to the malignant hypothermia service at the hospital that I've chosen to anonymize as Moordale. The trouble is the genetics team have referred people to Moordale before, and they're profoundly dissatisfied with the way in which Moordale goes about things, in that as far as the genetics team are concerned, there's no way that Moordale will ever give this guy a clean bill of health. So, as Kerry puts it, you are not going to get a clear answer from Moordale. Is it just going to be a waste of time and create all sorts of questions and issues, and it's just safer just turn around and say, we consider the family, i.e. the father's side, all over here, who aren't actually on the map, on the diagram. Is it just safer just to say, look, you're at risk of malignant hypothermia and your family. There's no point going for clinical follow-up at Moordale. This will involve things like muscle biopsy. It's quite intrusive and potentially quite unpleasant. But with no guarantee, in fact, almost no certain, it's almost certain that Moordale won't give the guy a clean bill of health. So if Moordale are going to say anyway, yeah, he's probably at risk, then why not just skip that process and just say, actually, the VUS, it's definitely pathogenic. So your family, your side of the family are definitely at risk. You need to be careful about malignant hypothermia. And that's actually what they decided to do. So the classification of the variant as whether it's a variant of uncertain significance or likely pathogenic is, at least in part, on the basis that classifying it as a VUS will lead to more clinical interventions, which actually won't help make a decision about it anyway. Finally, the third example of, if you like, a clinical warrant is concern over the workload that this will produce for other clinicians. So this is, they're talking here about CMT, which is Charcot-Marie tooth disease, which is a nerve disorder. And they have a VUS. To really resolve the VUS, they would have to go back to the referring GP and ask for them to track down the other members of the family and to look for other features of Charcot-Marie tooth. And as Alan puts it, that reporting, i.e. reporting the VUS as, reporting it as a VUS is going to create a package of work for that particular clinician who will conscientiously do it, because obviously there's going to be a workload issue for that, because it's going to require, and then, you know, there's a bit of joking about the workload for individual clinicians in the room. There's an issue, workload issue for the lab. And they're uncertain that it would change the, they're uncertain that it would change the classification from the VUS. Okay, so those are clinical decisions. Now it's start getting a bit vaguer. So I think there are occasions when the team we sat with classified variants in one way or another in order to shape patients' behaviors. So this is what I call a behavioral one. So the easy one is you don't report a VUS because you don't think the family is going to be able to handle it. This is an instance where actually the family are already getting information on 2 other variants, which are clearly pathogenic. And James, who's met the family, and in these sorts of meetings, meeting a family face to face has quite a powerful trump value. So James is not the most, you know, these aren't sort of pathologically hierarchical organisations meeting. But you know, James is not the most senior person in the room, but he has a trump because he has met the family. And that gives what he says in these meetings a certain strength. And James says actually he thinks that they'll obviously report the 2 pathogenic parents to the family, but he would, you know, they're getting that anyway. You don't need to make things more complicated for them by also saying, oh, by the way, you've also got a 3rd variant that we don't really know what it means. It's a VUS. So the decision there is about is one about I don't know whether the label behavioural works there, but you're taking into consideration how the parents in this case will react. This is more obviously an attempt to shape patient behaviour. Again, this is quite a complex case, but this is a prenatal. The team have ended up with a prenatal result, which in an ideal world, as far as they're concerned, if they had had their say, wouldn't have been tested. There's no way this fetus would have been tested. There's no way this fetus would have been tested for the condition that it was meant to be tested for. It certainly wouldn't have been tested for this condition, which is an incidental finding, which wasn't meant to be there. There's no clinical indication of this. So ATRX, which is quite a severe developmental disorder. And they have a VUS. So they've been presented with this is an example that I would have talked about in my previous case, my previous talk, which I was due to do, which is about mainstreaming and about letting people who aren't geneticists order genetic tests and why it's a bad idea. And this is a really good example about why it's a bad idea. So the team have to decide what to tell the mother, who is anxious anyway, who's anxious for a load of reasons, not least of all because she knows there's something wrong with the fetus. They're trying to decide how to report this VUS. So Nikki says, I mean, I'm not entirely comfortable reporting it as benign. And Bob, who's a consultant clinical geneticist, replies, no, this is not something we are absolutely comfortable with, but you know. Nikki continues, I feel like doing this, reporting it as benign in the absence of any family history or phenotypic information feels like a risk. Okay, so that's the important thing. They don't know enough about this family because someone else ordered this test. This result has ended up on their laps. This isn't a patient who's made their way through the system here. This is if you like, this stuff has been dumped on this clinical genetics team. So there's quite a long-winded debate, and the decision is that if you report it as a VUS, it's probably benign, but if you report it as a VUS, then that's going to encourage the family to come in. Because you're going to say, look, we don't know enough about it, we need you to come in, we need to have a meeting with you, we need to get a bit more information about your family. So as Sally says, you are reporting it as a VUS because you want that conversation with the clinical team who will then be able to look into the history of that family. And for me, that's the only reason we're doing it. That's the only reason it's being reported as a VUS rather than a benign. It gives her an opportunity to come and speak to the expert. And gradually over time, other members of the team buy into this way of thinking about this particular variant. So Sally continues to push this argument. So as far as I'm concerned, the classification is very much likely benign, but as far as reporting we're reporting for the clinical care of that family. So it gives you an opportunity to meet the family, discuss this over, and make sure there's nothing suspicious going on in that family. As Nikki says, I know intellectually it feels a bit weird, but clinically it's a different thing, isn't it? Actually, it didn't work terribly well. The parents were very unhappy with the idea of coming in and actually disengaged from the clinical genetics service and didn't come in. The positive thing is, in the end, a child was born and was tested and didn't have ATRX. So actually, it all ended up fine. The attempts to shape the behavior of the patients, or the parents, to encourage them to come in, to encourage them to engage with clinical genetics. So shaping them by saying this result is a VUS rather than this result is a benign, actually it failed. It didn't work. It didn't shape the behavior. Okay, so this is the third and final kind of actionability that's useful. And this is where a genetic result has an administrative or a bureaucratic value. So this is a case. So Andrea talks about a girl. The mother brought a child via the GP in for Fragile X syndrome. The girl has quite serious behavioural problems. Maybe it's Fragile X. Andrea sent her DNA for testing. It's a VUS on chromosome 10. And then the story begins to unravel. It's actually the mum and dad are separated, and dad is pursuing guardianship on the children. And then both sides, both the mum and dad, have caught onto this genetic variant, which actually is probably VUS, probably doesn't mean anything. And Andrea is beginning, given that the mother is phoning her every day and has somehow got hold of her office phone number, beginning to regret reporting this VUS at all. And the VUS is playing a role in the guardianship legal debate between the mother and father. So I'm getting phone calls from the mother, from her every day, saying, oh, their dad's taking me to court saying I'm lying about this chromosome Q or the chromosome 10 problem. And the idea is, as the discussion goes on, the argument would be that if the child's behavior is due to a genetic variant, then it's not because the mother is a bad mother. It's not because the mother is neglectful. It's a genetic condition. And that, if you like, that removes a particular option from the father's legal claims to for guardianship of this girl and her sister. So there's a, if you like, there's an administrative or a bureaucratic value to these kinds of results. And in fact, it's inevitably, it's of all the people in these meetings, it's Alan who actually spells this out really clearly. So this is a discussion about a separate case, another VUS, and Alan sets it out. Depends what in genetic counselling terms you need a result for. I mean, clearly one would be extremely cautious about using this variant in a prenatal setting. But if it's to batter some school head over the issue of resources, because if your parents just need something in a box and put Kleefstra syndrome type 2 brackets to parents who are only about 85% sure about that, it might change in the future, but you can still get your child's extra education needs. That may be enough. They'll go away happy. So if this is, I don't think, to draw on my colleague Harry Collins' favourite way of thinking about data, I don't think this difference between ways of these kinds of one, I don't think this is an analyst category. I think it's an actor's category. I think it's there in the discourse and Alan is setting it out clearly. This variant, we'll call it pathogenic for bureaucratic purposes, but we won't call it pathogenic for purposes of termination of pregnancy. We're not certain enough for that. So its actual status, or its status on pieces of paper that get reported outside this clinical meeting, varies according to what you're going to do with it. And this stuff here has echoes. This has echoes of Stefan Timmermans' work. This is from interview with parents of kids with quite serious conditions and who go through a clinical exome sequencing service. But there's an acknowledgement about the administrative warrant for accessing services, the bureaucratic value of a diagnosis, of a genetic diagnosis. It opens up resources for you. And I have on my recordings, and I cannot find it, but I was in the meeting, so it must be there, and I'm desperately searching, a clear conversation with a psychiatrist where he says, well, look, sometimes when you have kids who are on the margin between developmental disorder and autism, and you've got to decide which of those they have, under the setting that we're talking about, if it's autism, then there are no genetic services. You can't genetic test for autism, although there are genetic variations that are associated with autism, but there is bureaucratically, you can't send DNA for testing for autism. But you can send DNA for testing for developmental disorder. And in a lot of cases, symptomatically, there's an overlap. So he does talk about the way in which sometimes he will classify a child as developmental, even though there are quite strong autistic symptoms, but classifies them as developmentally disordered in order to get them into the genetic testing pathway. And lo and behold, you discover there are large copy number variants that are tend to be associated with autism spectrum disorders. So, but I swear blind that was there. I still just haven't found it in my recordings yet, but I will. I've got to filter through. So that's kind of it. I mean, is there something there? So this is the if you like, there's the central insight that the actionability of a specific test result is not a destination at the end of decision making around genetic uncertainty, but rather is a component of that decision making. I'd be really interested to know what people think, whether there's something else happening in the data or whether it links to other work, anything you know about. Thank you.